Yes, so thank you. It's my pleasure to have the first oral presentation here. I'm Lisanne Bevers, and I'm a PhD student and pharmacist of the Pharmacokinetic team of the Radboud University Medical Center in Nijmegen, the Netherlands. And on behalf of the CHAPAS-4 trial team, I'm presenting here the first PK data of Dolutegravir in combination with a TAF-containing backbone in children living with HIV. So first, the reason I want to present these results. So one of the currently recommended regimens for HIV-infected children consists of 2 NRTIs as a backbone and the INSTI as an anchor drug. And TAF is one of the recommended NRTIs in children. It's a product of tenofovir, and compared to TDF, it causes less renal and bone toxicity and therefore is preferred over TDF in children. And then for the INSTIs, Dolutegravir is one of the preferred ones in children. It is very potent, has a high genetic barrier to resistance, low toxicity, and once daily dosing is possible. And well, together they will therefore be widely used, but we did not investigate this combination in children earlier on. So therefore we do not have PK data also on the combination of Dolutegravir in TAF and TAF in children. But this CHAPAS-4 trial made it possible for us to investigate this combination. So CHAPAS-4 is a trial in which children aged 3 to 13 years old failing on first-line ART were randomized to 3 different anchor drugs, and one of those anchor drugs was Dolutegravir. And then in a factorial design, were randomized to either a TAF-containing backbone or standard of care. And so we selected all the children on Dolutegravir. And with this PK study, the aim is to present the data of children using Dolutegravir and a TAF-containing NRTI backbone and compare them to the standard of care. So we dosed the children according to the WHO weight dosing. So the children below 20 kgs received 25 milligram dispersible tablets, and the children above 20 kgs received 50 milligram film-coated tablets. All children received a standardized breakfast before taking Dolutegravir, and the aim was to include at least 4 children per wavelength per group. We measured the Dolutegravir concentrations and drawn a 24-hour curve, and we performed independent sample t-test on the log transformed data, and we will present the ratios with the 90% confidence intervals. So in the end, we included 41 children for this PK sub-study. And here this slide shows the demographics of both groups. They were randomized, so the demographics are almost the same, and the demographics are shown as median and range. So here are the first results of the PK sub-study. On the x-axis you see the time, and on the y-axis the mean Dolutegravir concentrations. And then the black line presents all the children on Dolutegravir in CHAPAS-4 in the CHAPAS-4 PK study, and on the TAF line is the blue line, and the green line presents standard of care. Well, and at the first glance we see that the TAF-containing backbone group has a slightly lower exposure for almost all time points on Dolutegravir. Then this slide shows the pharmacokinetic parameters, and they are expressed as geometric means with coefficient of variation, except for the Tmax, which is expressed as median and interquartile range. But I will use the following slides to point out these differences. So first, for the geometric AUCs, here you can see the difference between TAF and standard of care. On the y-axis you see the geometric mean AUCs, and with 95% error bars. And we calculated the AUC geometric mean ratio of TAF versus standard of care, which is 0.77, which means that the children on TAF had a 23% lower exposure on Dolutegravir. and this was also statistically significant. Then for the same graphs for the C troughs and the C max, well, on the left, the C troughs, there we see a 26% lower exposure of dolutegravir in the TAF group, but this was not statistically significant. And for the C max group, we see a 21% lower exposure. And this was also statistically significant. Then if we divide the exposure in our different waistband groups, we see that for the same trend is seen for almost all waistbands, and also the waistband below 20 kJs is also 20 to 30% lower, and this was the group who received the 25 milligram dispersible tablets. So we see the same trend in both tablets. And then we plotted the individual C troughs of TAF versus standard of care, and we set the target as 0.32, which is the minimal effective concentration, and reported EC 90 of dolutegravir. And then the black line, the horizontal black lines, reports the geometric means, and we see that only 2 patients are below the target, but they were both from the TAF group, and we could not identify particularly reasons why they were below the target. And then this CHOPUS-4 PK substudy was also the first study in which dolutegravir was taken with food, because in Odyssey, for example, the children on dolutegravir had received dolutegravir after an overfast night. So therefore, we want to compare our data in CHOPUS-4 with the data we have in Odyssey. And for this sub-study, we have to compare 2 different trials. So also we have to deal with different dolutegravir sample schedules. So for the CHOPUS-4 trial, we had an extra 8 and 12-hour sample, and for the Odyssey trial, we had a 3-hour sample, and the difference was in the food taken before dolutegravir. And we again did independent sample t-test, and we'll present the ratios with a 90% confidence interval. So these were the demographics of both groups. We used only the standard of care group of CHOPUS-4 because in Odyssey the children also received dolutegravir with standard of care. And again, this is shown as median and range. Then here you see the first results. Again, a plasma concentration curve, so time on the x-axis and mean dolutegravir concentrations on the y-axis. Well, and at the first glance, we see no difference in exposure in both trials, except for the, somehow delayed absorption phase and therefore Tmax, which we see in CHOPUS-4, but this is also a known effect of when we take dolutegravir with food. Well, we were particularly interested, of course, in the exposure. So here we report again a box plot with the geometric mean AOCs in both trials. And we calculated again the geometric mean ratio, and we saw no difference in exposure, and nor was there a difference in Cmax and C trough levels. And then, of course, we have some discussion points. So for the study itself, so the CHOPUS-4 PK sub-study of dolutegravir, in which we compare the TAF group with the standard of care group. We are in doubt in what is the clinical relevance, because we still have no viral load data yet. The study has not yet ended, so we could not identify if the 2 persons below the C trough levels so the C trough levels are below the target if they are also failing on dolutegravir, but the mean C trough levels are all above 0.32, and also we are not the mechanism is not clear yet, And yeah, so that are some discussion points to consider. And then for the PK comparison of our vet dolutegravir CHOPS-4 data vs the Odyssey data, well, we have to deal with a different trial, with two different trials. So also, we did not randomize the groups. There was different trial sample schedule, but well, it was the best we had, and it gives us a first glance and some preliminary interesting results we didn't expect. So in conclusion, this PK sub-study within CHOPS-4 shows that the exposure of dolutegravir in combination with TAF in children is 20 to 30% lower than with standard of care. And we could also not confirm in this PK sub-study a food effect in children on dolutegravir exposure. And well, lastly, I want to thank the entire CHOPS-4 trial team, and especially all the children parents, carers who made it possible to have successful PK days and therefore have these interesting results. Thank you.